Hi friends, so with INI-CET exam approaching, we always have this thing that we have to do new drugs before INI-CET exam because INI-CET tends to ask at least one question on these drugs. So that's the reason we are having this session. The PDF of this, both blank and annotated PDF, will be available for download on MedSynapse App by Dr. Nikita. And you can download it from there. So let's quickly start discussing. In this session, I'll not just tell you only the drugs, I'll tell you some easy tricks to remember also those drugs. So starting with first one, oncology, the cancer wale drugs, targeted therapies and biologics. So you have antibody drug conjugates and monoclonals, ADCs, that is antibody and a drug conjugate. It is conjugated to another drug. For example, the first one that you see here, datopotamab deruxtecan, right? So this monoclonal antibody is a conjugate with this another drug. From the name you can see this is Tican. So like from the anti-cancer drugs that we have discussed in SureShot course. So Ticans, like irinotecan, it is topoisomerase 1 inhibitor, right? So that is why you have this drug as well, which is datopotamab. Topo ke saath ja raha hai. So when you look at the spelling of this drug, it is TOP, and the reverse also you have TOP, top and top. So top is coming two times. So remember it is top2, that is TROP2 targeting drug. It targets TROP2. And we have two lungs and we have two breasts, right? So what is it used for? Breast cancer and non-small cell lung cancer. Which breast cancer? Which is HER2 negative plus but hormone receptor positive. Coming to next one, telisotuzumab, which targets c-MET. Again, this is used for lung cancer, non-small cell lung cancer. Remember, it's TEL, reverse is LET, LET is MET. Okay, so it is inhibiting, it is targeting c-MET. This is also your ADC drug with a conjugate. So this drug goes to the MET wale cancer cells and then it releases a substance which is microtubule inhibitor there called as MMAE. So remember telisotuzumab, tel is let, which is MET, and this is for lung cancer. Next one is margetuximab, which targets HER2. Other HER2 drugs which you know is trastuzumab and lapatinib, very, very important. This has been asked in INI-CET previously. Another drug is margetuximab. So remember this as like Margarita, a female named Margarita getting breast cancer, HER2. So HER2 Margarita getting breast cancer. Next one is cetuximab, very, very important. Cetuximab inhibits EGFR, which is HER1. EGFR, which is HER1. So remember cetuximab C4C, it is used for colorectal cancer and where we wear the cap, that is head and neck region. So head and neck squamous cell carcinoma, colorectal carcinoma, that is what it is used for. Remember in the EGFR pathway, first in the signaling pathway, you have EGFR, then you have KRAS. So for EGFR inhibiting drugs to act, the KRAS has to be normal. It should not be mutated because if it is mutated, automatically the EGFR drugs will not be able to act. So remember, this is specifically used for KRAS wild type, not the mutated type. The KRAS should not be mutated because if it is mutated, automatically these drugs will be ineffective and there will be intrinsic resistance. Okay, so cetuximab, EGFR, HER1 inhibitor. Going to next one, mogamulizumab, which targets CD194, CCR4, which is T cell. Remember M for M, the cutaneous T cell lymphoma, mycosis fungoides. It is used for mycosis fungoides. When it goes into the blood, it is Sézary syndrome. From our SureShot course, we know the mnemonic for Sézary syndrome pathology. What cells, what nucleus does it have? Sézary is seizures. Remember it like that. Seizures coming from the cerebrum. It is cerebriform nucleus. Okay, cerebriform nucleus is seen here. So mogamulizumab, mycosis fungoides. Remember, like Mowgli having mycosis fungoides. Coming to immune checkpoint inhibitors, very, very important for INI-CET, PD1, PDL1. PD1 present on T cells, PDL1 present on cancer cells, right? So that interaction, if it is not happening, the cancer cells will not be killed. So this immune checkpoint inhibitor, the PD1 inhibitor, the mnemonic that we know from a SureShot extra H is put Nivea cream. So PD1 is put Nivea cream. Add to that list, put Nivea cream with a red pen. Imagine you have a red pen and you're putting Nivea cream with a red pen. So you have P, put is pembrolizumab, Nivea is nivolumab, cream is semiplimab, pen is penpulimab, and red is retifanlimab. Okay, REER. Remember ER in Merkel. For Merkel, you have this RE wala drug. Merkel cell carcinoma. Again, remember the mnemonic that we have seen, which is what? CK positive. Remember the mnemonic MERCO20, Merkel cell colorectal colon cancer is CK20 positive. Okay, the CK20 positive. Coming to PDL1 wala mnemonic, what is the PDL1? L1 for L, LADA, ADA, the A and the D drugs. Avelumab, Durvalumab, Dostarlimab, and Atezolizumab. Okay, so that is LADA drugs, that is PDL1. So please remember which is PDL1 and which is PD1. Put Nivea cream with red pen. Okay. Going to next one, kinase inhibitors and targeted agents. So adagrasib. So like you see here, this is RAS. It is RAS inhibiting drug. The target is KRAS. Okay. So it is used in non-small cell lung cancer specifically, which is with this G12C mutation. It halts the tumor growth there. Okay. So remember adagras, the G for G12C mutation wala. Okay. Olaparib, Rucaparib, previously as INICET question, Parib. Okay, so what is Parib? P-A-R. From the spelling also you can know these are PARP inhibitors. PARP inhibitors used in BRCA mutated ovarian cancer. Okay, Parib and Parib. BRCA वाले में use करते हैं ovarian cancer में. Then you have cyclib drugs. Cyclib is cyclin dependent kinases, CDK. So abemaciclib, palbociclib. Remember palbociclib, this is used in breast cancer. It arrests the cell cycle in G1 phase. So remember, like cyclib, CI is like GI, it is G1 phase arrest. Okay. Then you have tezemetostat, metostat. Okay, so these are the drugs which is meto ko stat kar raha hai. Meto is methyl transferase. The histone methyl transferase is what is being inhibited. The histone methyl transferase is given by this EZH2. So remember E for E, EZH2, EZ inhibiting ES, epithelioid sarcoma. So basically, you know, this is epigenetic modifier, the methylation, acetylation, covalent modifications are your epigenetic. So this is epigenetic modifier, which is tezemetostat. Going to next one, the DAGIBs and the DAGIBs, DEG. Remember DEG wale drugs is your the hedgehog, DGE, DEG. Hedgehog pathway is what they are inhibiting. Hedgehog pathway important in basal cell carcinoma. These are called as smoothened inhibitors, SMO proteins inhibitors, smoothened inhibitors. Okay. So remember, like you have sonic hedgehog, SON, SMO inhibitors. Okay, sonic hedgehog. The DEG is going to be DGE hedgehog pathway, basal cell carcinoma. Going to next one, hematological malignancies, multiple myeloma. Previously asked question, what is ZOMIB? ZOMIB. Zome is SOM. What SOM? Proteasome inhibitor. It is proteasome inhibitor. So which are the proteasome inhibitors? What is ZOMIB? Carfilzomib, ixazomib. Zomibs are proteasome inhibitor. So they are blocking the proteasomes. So that is why there is accumulation of toxic misfolded proteins and that leads to apoptosis. Multiple myeloma, plasma cell tumor, Ben-Stone's proteinuria, right? Remember you have plasma cells which is CD38 positive, right? So CD38 targeting antibody. You have daratumumab and isatuximab. So remember this as Isha Dara. Imagine like this is the name. Isha Dara has multiple myeloma. Okay, so Isha Dara, multiple myeloma. What is the age? 38 years. To remember, it is CD38. So 38-year-old Isha Dara has multiple myeloma. Next is exportin 1 inhibitor. So exportin, you have EXO exportin inhibitor, selinexor. Okay, selinexor. This is also for your multiple myeloma. Going to next one, leukemias, lymphomas, venetoclax is your BCL2 inhibitor. You know BCL2. CL, the cell lives long life. It is anti-apoptotic factor. So when that is inhibited, the apoptosis will come into play. So this restores the apoptosis in CLL, venetoclax. So the cells Cl, remember in CLL the cells become lax, okay, and they go into apoptosis, went into lax mode, venetoclax, because the BCL2 is inhibited. Then you have CD20, very important, which is present on B cells. One is rituximab, the famous monoclonal antibody. You should definitely know this, CD20. Another one is OFA2-MUMab. Okay, so you have Ritu and OFA, which is CD20. Okay, so 20-year-old Ritu saying fa, OFA. Okay, so remember 20-year-old Ritu saying OFA. CD22 is epratusumab. Okay, and then you have these PI3K inhibitors. Remember these drugs and in LYSIB. The PI3K, like you have phosphatidyl inositol. Okay, so remember phosphatidyl inositol, LILI. So the LYSIB drugs coming in here. So you have Idela LYSIB, Copan LYSIB. You might just be given the names of the drugs and you'll be asked by what pathway they are acting. Is it PI3K? Is it your CDK4/6? Is it your hedgehog? Right? So you should know the names at least. So like PARP drug was asked, PARP is PARP. Similarly, you might be asked this. LYSIB is your phosphatidyl inositol, LILI, the PI3K inhibitor used in refractory lymphomas. Going to neurology, psychiatry and pain, the pain and migraine, a new drug, suzetrigine, which is the first in class, the sodium, right, NAV, sodium voltage, like remember 1.8 voltage gated sodium channel inhibitor. It is non-opioid analgesic for acute pain. Remember Suzanne Khan gone into pain, Hrithik Roshan ne chhod diya, so suzetrigine, that is for pain, which is your NAV. Okay, NAV. So Suzanne was very naive, and she got into pain. So Suzanne, naive, which is sodium voltage gated channel inhibitor, non-opioid. Very important for acute migraine, lasmiditan. Remember, is your 5-HT1F agonist. Like in acute migraine, we use triptans, which act on 5-HT1B1D. But the problem with triptans is they cause vasoconstrictions. If a patient has MI, so that can ischemia, that can lead to MI. So that is why when you want in a patient with previous MI, coronary artery disease, acute migraine drug, then you will have lasmiditan. Okay, remember lasmiditan. MI for MI, this is used in migraine. Okay, this is used in migraine. Is this clear with everyone? 5-HT1F agonist. Okay, this is 5-HT1F. Is it clear with everyone? Okay, going to next one, Parkinson's and movement disorders. Pimavanserin is a 5-HT2A inverse agonist. So what happens in a Parkinson's patient when taking levodopa, excess of dopamine, it leads to psychosis. So when there is levodopa induced psychosis, you want a drug, for antipsychotic drug. But at the same time, that then antipsychotics can cause Parkinson-like symptoms, which you do not want. So when you do not want to worsen the motor symptoms, so you will use a drug which is not acting on as an anti-D2 receptor, but this 5-HT2A inverse agonist, pimavanserin. Remember serin. Serin is like serotonin, inverse agonist, IN, which is on 5. The V is for 5. Okay, so 5-HT2A inverse agonist. Okay, pimavanserin. And remember, this is Parkinson. Pim is like PIM, Parkinson's induced mood abnormality, that is psychosis, which is there, which is pimavanserin. Parkinson's ke wajah se, Parkinson drug ke wajah se. On-off phenomenon in Parkinson's, they are managed by, remember, ON is like OM, the OM-COMT inhibitors, C for capons and capons. These are your COMT inhibitors. Then you have another OM here, ONM, the MAO-B inhibitor, which is safinamide and selgiline. Remember, S for SS drugs come here in MAO-B. Then you have estradiol, adenosine wala, A2A antagonist, adenosine ADE. So that is what you have here. Estradiol drug, ADE. So these are the drugs for on-off phenomenon. Okay. Then you have tardive dyskinesia, VV drug, the valbenazine, which is VMAT. So remember VVV for tardive. Valbenazine, VMAT2 inhibitors. The VMAT2 basically preventing the dopamine okay, from coming into the presynaptic vesicles and their release. So it is decreasing the dopamine release, the presynaptic dopamine release. Tardive dyskinesia, you have valbenazine and deutetrabenazine. Okay, this has been asked in INICET exam again. Tardive dyskinesia. Then you have ALS, amyotrophic lateral sclerosis, Alzheimer's and epilepsy drugs. For ALS, you have a new drug, tofersen, which is your SEN, is your antisense oligonucleotide, which is targeting SOD1, SOD1 mRNA mutation. Okay, SOD, superoxide dismutase wala. So remember tofersen, ALS, SOD1, SEN is your antisense oligonucleotide. R for this RNA mutation, SOD. Okay, so TOF, SOD. So that is TOF and SOD. Okay, then you have riluzole also used here. Riluzole is NMDA antagonist. NMDA basically causing excitotoxicity in the brain. So NMDA hum block kar dete hain, riluzole. Then you have edaravone, which is free radical scavenger. The free radicals again causing the damage. So edaravone is a free radical scavenger. So know these three drugs in ALS and know the mechanism of action. Remember in ALS, AL is for all, that is UMN plus LMN, both is involved in ALS. Okay, so riluzole, edaravone, even this has been asked in the exam, and tofersen. TOF is SOD. Alzheimer's disease, aducanumab, remember new for some neural condition. AD is for Alzheimer's disease, aducanumab. Okay, so this is against your beta amyloid plaques. A for amyloid plaques. Epilepsy, tiagabine, remember GAT1 inhibitor. So basically what is taking up the GABA, that is inhibited. So that is why the GABA increases. In epilepsy, you want to increase the GABA because GABA is like, you know, depressant action on the brain. So brain ko shant karega. So tiagabine is your GAT1 inhibitor. Again, a recently asked question. Rufinamide, one is your NANA, it does act on sodium, plus it is your mGlur5, which is basically your glutamate receptor. Again, glutamate, excitic, right? Cytotoxicity. So, rufinamide, RU is your UR, the glutamate receptor. Okay, so rufinamide. Lacosamide, one of the recently asked questions. Lacosamide, SLO, which is slow sodium. Okay, slow, again SOD, slow sodium inactivation is what it acts on. Other anti-epilepsy drugs, they act on the fast inactivation, but this specifically acts on slow inactivation. So this is sodium channel and CRMP2 inhibitor. Okay, sodium channel and CRMP2 inhibitor. Yes. Right, so far we have covered a lot of drugs, like you can see. So the rest of the drugs that you have in the new drugs, which is including drugs for infectious diseases, the CVS system, endocrine, GIT, and some immunology rare diseases, this we shall be covering in the part 2 of the video for this topic. So again, a reminder, you will get the PDF on MedSynapse App by Dr. Nikita, both blank and annotated. And please make sure you revise these before your INI-CET exam, because specifically I've included the drugs which have high chances of being asked in the exam and also the ones that have been asked in the past. Thank you so much.